As if you've been on one of these presentations, the three prior presentations, previously, you'll know that I like to begin the presentation with some data and statistics. So our presentation objectives are going to begin by looking at the cost relationship between co-occurring conditions. And when we talk about costs, we're just not talking about dollars and cents, but we're talking about the human toll that chronic pain and substance use have on the individual, the families, the work environment, lost productivity, and broken relationships, and those kind of human cost factors. We also will look at the impact on the clinical quality outcomes on patients with co-occurring conditions. And there's no doubt that many of your patients that are dealing with chronic pain or substance use also have other chronic conditions, hypertension, diabetes, cardiac issues, whatever that may be. But if they are addicted to substances or dealing with unremitting chronic pain, those issues can become secondary to them and have a profound impact on the clinical quality outcomes to improve their lives. So what we're hoping to look at is the ability to develop a plan of action for your practices to consider in dealing with those two issues. Next slide, please. On this slide, you'll see the dollar and cents implications of the impact of co-occurring conditions with substance use and or mental illness. And I want to call your attention to the right-hand portion of that slide, because diabetes and hypertension are likely one or two of the top 5 diseases that your practice is dealing with. And you can see from the blue bar on this graph the cost implication of co-occurring mental illness and substance use disorders, as well as just mental illness and just substance use. So there's no doubt that from our experience, and there's plenty other data to support this, that these co-occurring conditions are driving up the cost of healthcare exponentially. And that's why we're seeing so much emphasis placed on substance use and behavioral health from funding sources, because they know that there is a direct correlation on cost, both dollars and cents, and, as I said previously, on the human dynamics. Next slide, please. On the human dynamic cost side, here are some statistics that you've probably seen similar data from your own local newspaper and news sources, where the continuing increase in the deaths associated with opioid overdose is certainly epidemic proportions, with many overdoses occurring in a single day in many of our communities. And sadly, it's the leading cause of death for individuals under age 50. And here again, it's having a profound impact on our cost of care because of the high utilization of inpatient admissions and emergency department visits. And that data is only through 2014. So I'm sure when we look at the data through 2016, it's probably far higher than this, because the opioid addiction and chronic pain problem is spiraling somewhat unabated throughout our country. Next slide, please. What we want to look at is the relationship between mental health and chronic pain, and then we'll get into substance use in a couple of minutes. I would like you to associate the impact of chronic pain with a person's ability to cope on a daily basis. When someone is suffering from unremitting chronic pain, and I'm sure you may know of someone in your own family, in your practice, I know it hits close to home, an immediate member of my family. That does impact the ability to concentrate. The sleep deprivation leads to potential anger and mood swings. They can't participate in the daily life activity the way they used to, as far as recreating, family interaction, participating in work, lost productivity from absence from work, leading to suicidal ideations, and the real potential for the addiction to opioid prescribed medication. So what we have to look at is what plan are we going to have in place to deal with these individuals that are suffering from chronic pain. And these are just a partial list of the related factors that a person with chronic pain is going to be dealing with. Next slide, please. I suggest to you that if you are involved in a chronic pain management program or thinking about starting one, that you really need to hang your hat on an evidence-based best practice model in order for you to successfully manage the requirements today on those programs. In the recent past, I worked with a physician practice here in Ohio that ran a pain management clinic and also a substance use clinic. Unfortunately, I got involved in that practice as a consultant too late in order to really help the practitioners discover the need to follow evidence-based best practices, to document what they're doing, and to really document any deviation from those best practices to the point where they failed an audit and had some really serious consequences for the practitioner and the practice. So this particular evidence-based best practice model that I chose for this presentation comes from the CDC Guideline for Prescribing Opioids for Chronic Pain, and it's a 2016 edition. The guideline has 3 domains and 12 recommendations within those domains. And there's a variety of additional guideline resources at the CDC. Also, the Substance Abuse and Mental Health Services Administration has several resources available that can lead you to evidence-based best practice models. And I would suspect that the Michigan Prescription and Opioid Abuse Task Force also has some recommendations for practices that are considering or involved in chronic pain management and substance use. But as I said previously, I can't emphasize enough how important it is that you have explicit policies and procedures that deal with a minimum of risk assessment. There are risk assessment tools that you can use just like you would for behavioral health screening, where you may use the PHQ-9 and the GAD-7. There is the ORT, opioid risk tool, that patients take themselves to forecast their risk of addiction. There's the SOAP tool. It comes in 24, 14, and 5-question versions. So when you're looking at being involved in a program like this, it's going to protect you and better serve your patients if you're really vested in an evidence-based practice model that has a very clear policy and procedure operating requirements, and one of those requirements is to document why you're deviating from your own policies and procedures. It's also very important that you understand the requirements of CFR 42 Part 2. If you are using a HIPAA consent form for your substance use patients, you could very well have a problem because the regulations treat substance use patients differently than HIPAA consent. Just recently this year, March 21st, I think, SAMHSA finally updated the regulations for substance use individual consent. And it is a tremendous step forward, but yet I don't think it went far enough in making it easier for providers to share information involving substance use patients. So that is a regulation that if you're holding yourself out to be a chronic pain management program and or substance use program, you really need to become familiar with that regulation. Next slide, please. Similar to chronic pain, we want to be able to associate the impact of substance use with a person's reason for being addicted, especially if there's self-medication involved. Just providing Suboxone alone, for example, as this one clinic that I was consulting with, did not go far enough, in my opinion, to prevent the practice and the provider from being able to demonstrate that they were doing more than just providing medication-assisted therapy. It's really important to drill down into the root causes for that addiction and self-medication. And as you do that, you're going to have to uncover a course of treatment. And here again, there should be identified in your written policies and procedures as to what will lead you to prescribe a certain course of treatment for the substance use patient. Is it going to be Suboxone only, MAT, substance use counseling, behavioral health counseling, a sprinkling of all three? How are you going to integrate those services to make sure the patient is adhering to their plan of care and following the correct care pathway? Those are the issues that when we develop chronic pain management and or substance use program is going to be part of the process in developing a methodology for deciding the course of treatment that you'll employ in your practice. Next slide, please. Well, at this point, I'm going to turn it over to Dr. Mason, and then we'll follow up after his presentation.
Thank you, Rich. Just one correction. I'm a psychologist, clinical psychologist, not a clinical psychiatrist. Quite a bit of a difference there, guys. Next slide, please. All right, we're going to talk a little bit about substance abuse and addiction, and I think that we all can agree that substance abuse of any kind has become an epidemic, and it's very difficult for us to deal with. A lot of circumstances cause the abuse. Sometimes after the cessation of drugs, there's a move to get illegal drugs. It seems like the abuse of prescription drugs is increasing, although that's been a problem for many, many years. I recall in the early days when I was a psychological intern, we provided services at some of the welfare clinics that were one-stop clinics, and people would walk out of the clinic literally with bags full of medication, and they would sell the drugs out in the parking lot. So the use of or the abuse of prescription drugs has been around for quite a while. It's just that it's gotten worse. Here in Ohio, the big problem we have right now is the usage of black tar heroin, and I'm sure that is the case in many of the areas that you all represent that are here at this seminar. It's particularly bad in the rural areas because we don't have enough law enforcement to keep up with the usage. The other issue is that black tar heroin is readily available and it's cheaper than marijuana, and people prefer the high off the heroin. To give you an idea of how bad this problem is in Ohio, a sheriff in a rural county just issued a safety alert at the beginning of the week stating that the gang, I think it's called M13 out of Los Angeles, was planning on coming into his county and basically killing snitches, and also intended on flooding the market down there with the heroin that would actually cause overdoses or problems because of what was mixed with the heroin. That's a pretty ballsy move. Nothing's happened yet, but everybody's watching it pretty closely. Overdoses, on the other hand, are very, very common with the heroin. Sometimes 3, 4, or more reported overdoses occur in a single day in any community. A lot of what happens with the overdoses is the fact it's not really an overdose, but it is the fact that they've cut the heroin with something that is really dangerous, and that causes the overdose. I know one city here in Ohio had like 7 overdoses in a 24-hour period. And we get more and more all the time. It's to the point, at least here in Columbus, where we have first responders carrying naloxone on their units to administer to overdoses. There is some controversy over even administering this drug because there are some people who I'm sorry, I got interrupted. There are some politicians who feel that we shouldn't be coddling the drug addicts, and we shouldn't be treating them with the naloxone. I'm not quite sure what the alternative is, but as a paramedic, you know, you got to treat these people. You don't have a choice. So it seems kind of silly to me to not be using the drug of choice to help them. The other thing that's been going on, at least here in Columbus, I'm seeing that some citizens are going to their pharmacy, they're getting some quick training on how to administer the naloxone, and they carry it around with them, not because they have somebody in particular that they're concerned about, but just because they want to be prepared if they run into an overdose on the street. And that, in fact, has happened, and civilians have saved people with that medication. I talked to a paramedic here in Columbus a couple weeks ago, and he told me that the rate of overdoses has jumped 400% this year. That's a heck of a lot of overdoses, and it's not getting any better. So the heroin is a big issue, but there are many other illegal and legal drugs which are abused. On the legal side, oxycodone is one of the more popular drugs that's used. The state down here has tried to do a number of different things to try and regulate that, but they haven't really been real successful. Obviously, crack cocaine and marijuana are very popular drugs, in addition to crystal meth. And crystal meth is another major problem because you can build a crystal meth lab in the back of a van and move from place to place so you don't get caught. Give you some idea about how lucrative producing crystal meth is. We did work when I was in doing foster care and designing treatment programs for foster care. We had an operation in Chattanooga. Chattanooga used to be the hub for moonshine distribution. You know, all these little hollers and places up behind Chattanooga, up in the mountains, and yet people were making moonshine. They'd bring it into Chattanooga, and then it would get distributed out of Chattanooga. Well, over the past 10 years, these moonshiners have stopped making moonshine, and they make crystal meth. So now Chattanooga has a big crystal meth problem because of that. So economics play a major part in some of these substance abuse and addiction things, and you just need to know what the drug of choice is in your community. And once you do that, you need to learn the symptoms of the abuse. And, you know, if you have questionable cases, it's recommended that you do drug testing. I've always felt that drug testing was an important part of any kind of a treatment here, particularly if you're going to do treatment with the patient in your operation. Next slide, please. Alcohol abuse and addiction still represent a high risk in the community, though some recent statistics have shown that the use of alcohol by teenagers has dropped off somewhat over the last 5 or 6 years. But part of the issue why alcohol becomes a problem is the fact that it's readily at hand, and it's legal in most areas of the country. And what I see happening and what other people see happening is the alcohol is often used as a short-term method of self-medication to escape life stress or medical issues. I had an uncle who had throat cancer, was in a lot of pain, and what worked best for him was large doses of brandy. Probably not the best thing to use, but it gave him relief, so he used it along with his medication. And you're going to see a lot of that. People who have chronic pain, which we'll talk about a little bit here, also will self-medicate with alcohol, particularly if their medications are not managing the pain as much as they should. It's important that we identify the at-risk patients, and this is across the practice, not just for like chronic pain patients or another population. It's very important when gathering the history that we get a handle on past history of abuse. We also have a number of screening instruments available, which Richard had mentioned. Some of these tests can only be administered by qualified mental health professionals. Others can be used as screening devices when you are interviewing the patient. Treatment for substance abuse and addiction usually is outside the expertise of the therapist that's providing your psychological care within your clinic. This is not always the case, but substance abuse has become such a specialized area. For example, I don't touch it with a 10-foot pole. If I have somebody that's addicted, I'm referring them out to either a program or another therapist who has the expertise that I need to get this patient treated. However, I keep them in therapy for two reasons. First of all, continuity of care, And second of all, is to attack the psychological issues that have led to and reinforced the patient's substance abuse. So with these types of people, we're really going to be proactive in terms of following them in any programs outside of our clinical operation, because a lot of, in many of the cases, the therapy that the substance abuse person gets is behavioral, cognitive, changing patterns of behavior and usage without really paying a lot of attention to the core problem that precipitated the substance abuse in the first place. Next slide, please. Chronic pain has become a real bugaboo, a real focal point for a lot of practices because we're finally recognizing that there's a psychological component that goes along with the physical component that ends up being a major impact on the client's life. Chronic pain is just that. It goes unresolved and it can worsen over time. And so if you recall the stress model of major syndromes from way back when, like the first session we did, we know that the longer the stress condition continues, the more breakdown you get in the individual, and you end up having many psychological problems develop, such as depression and anxiety, as well as other conditions. In some of the more severe cases, I have seen actually the development of psychosis as the mind wrestles with how to deal with the chronic pain. An example that I would point out to you that I don't have here, but it's a very interesting study. A number of years ago, there was a study that was done at the Shriners Burn Center in Cincinnati, Ohio. And the Burn Center worked with all kind of severe burns. And one of the methods of treatment, particularly where you had whole body burns, was to soak the patient in these vats of disinfectant and so forth, and then they would scrub the dead skin off. Needless to say, that was a very painful process. So a group, somebody doing their dissertation, went in and administered MMPIs to the patients in the hospital. And what they found out was that a percentage of the people actually were floridly psychotic in nature. And they drilled down a little bit deeper and discovered that the majority of those patients were the patients that were going through this rather intense therapy. When these patients were released from the hospital and they weren't taking that therapy anymore, they were retested, and lo and behold, their psychosis was resolved. It wasn't there anymore. So the hypothesis there, and I think it's a pretty good hypothesis, is that the mind, when confronted with severe chronic pain, basically takes a powder. It creates an alternative universe, if you will, to avoid the pain, but it can pass once the pain is brought under control. Part of the problem that we've run into is that we've jumped on the bandwagon using opiates to manage chronic pain. The problem is the medications are addictive. When halted, when they're stopped, they're often replaced by other drugs, such as heroin or other street drugs. The other thing to keep in mind is that the pain clinics were developed to address better medication management and hopefully to reduce some of the abuse and addiction that was out there. Well, that's kind of been a mixed blessing because I think it's created more chances for abuse, particularly by the treating physician. Two incidents come to mind that that I think are very important to share with you because it points out how severely you can get into having your own problems and trying to resolve them with the medications that you're prescribing to the patients. The one case involved a pain specialist doctor at Ohio State University, and unbeknownst to the program, he was addicted to OxyContin. Well, he was smart enough not to write his own prescriptions, but what he did was he started making house calls on patients who were prescribed OxyContin. And his excuse was, I want to check to make sure you're getting the right medication. Well, what he would do is he would check the medication, but in the process, he would steal a number of the patient's pills, not enough that anybody would notice, but enough that he could beat his addiction. Well, this went on for quite a while until one of the patients finally got wise and started counting the medications because he thought it was odd that a doctor was making house calls. He reported it. The whole situation unraveled. The doctor went to jail, lost his license, and OSU got out of the pain management business. A second case just now got fired back up. There was a doctor who ran a pain clinic, and he was overprescribing. He was taking his profits and hiding them in some fake businesses. Was guilty of fraud. They caught him, and he was awaiting disposition. He cut a deal with the state. Part of that deal was to be able to tell on the other people that he had been working with. Well, last week there was a home invasion and he was shot dead. So, pretty serious consequences, okay? Pretty serious consequences. The other thing we have to look at is the psychological impact of the chronic pain. First of all, a lot of the chronic pain patients are industrial patients. They're blue-collar workers who have been injured on the job. A lot of those workers identify their self-worth with their ability to provide for their family. When they can't work, they get depressed, their self-image goes down, and they start to ruminate over how bad they are because of the injury. Some of these people end up getting suicidal, particularly as they get older, and the depression that they have continues to cycle downward, so they get worse. Next slide, please. Some other factors to consider. When you're looking at substance abuse, it's important to gain an understanding of how the problem developed for the individual. We know some substance abuse begins in early adolescent years, and that's a method of self-medication. The high they get off of the drugs gives the use an escape from the depression or other psychological issues such as bullying. The other thing that the other type of self-medication, quite frankly, is promiscuity, and you see that a lot in the adolescents. Both gives the youth some self-confidence in social situations, and they're accepted more. There's been a lot written about genetics being involved in substance abuse, and we know that some individuals inherit the gene which makes them more vulnerable. The operative word is vulnerable because you can look at a family that has a history of alcoholism or drug abuse, and some of the people within that family sphere have no substance abuse problems. And I think that it has to do with how those tendencies rub up against the environment to cause the issues to develop. It's just like with cancer. Some people may be prone to cancer. They may never get it because they aren't exposed to the carcinogen. But Some youth observe their parents dealing with stress through drugs and alcohol a lot more than, say, 15 years ago. And we know that kids model behavior by parents, and they will begin to model some of that behavior as ways to cope with their problems. Okay, next slide. Okay, Richard, it's yours.
Thanks, Dr. Mason. As we were talking about previously, the evidence-based practice guidelines contain benchmark metrics that you can use to initiate opioid treatment as well as ongoing monitoring for potential abuse. And I, again, selected the CDC guideline because that's a broad-based, evidence-based practice tool. And here's what that guideline contains. There's the 3 domains that I mentioned previously that guide the practitioner through the process of initiating and continuing treatment for chronic pain, how to select the appropriate dosage, the right medication, the duration, and the follow-up and discontinuation, which is very important to include in your policy and procedure, is the discontinuation process. And then, of course, assessing the risk. What we want to do when we're considering operating a chronic pain management program or substance use, and if you're already doing that, is having what I call a pre-prescribing plan. And that includes using an evidence-based program such as the one you hear on your screen. It also includes a couple of other factors that I've developed that I'll mention briefly in a few minutes. But as you can see, the recommendations include monitoring the use of MMEs, morphine milligram equivalents, as your benchmark metric. One of our SIPA practices that we're working with, the practitioner has developed a really good algorithm on chronic opioid medication use that includes MED and number of days involved in a particular dosage. But here, using the CDC guideline, as you'll see at the bottom of this slide, it gives you a benchmark metric to use for clinical professionals to reassess the evidence that individuals and the benefit they'll get from it and the risk that they impose. And it's really important, I think, to include some kind of risk stratification process in your program. That may include, but not be limited to, a psychiatric evaluation, psychological testing, certainly assessing for mental disease, again, using the PHQ-9, the GAD-7, as well as those 2 screening instruments that I mentioned previously. This is all before you're prescribing opioid for chronic pain management. So establish your guidelines and your policies and procedures up front. Manage your risk by assessing the risk of the patient to benefit from your treatment regimen and the risk of them becoming addicted. Next slide, please. The algorithm continues. The domain number 3 recommends using the state prescription drug monitoring program. This is becoming more and more standard, certainly in Ohio, where in 2017, the Attorney General's office did an analysis of the number of physicians that were not involved and signed up to use the OARS program. OARS is the program in Ohio where you can track patients to see if they are pain medication seekers, as well as the physicians that are prescribing pain medication. And certainly urine drug testing is also one of the recommendations in the CDC guidelines to be used before starting opioid treatment and during opioid treatment. So as we look at the components of setting up a pre-prescribing plan for your chronic pain management program and substance use program, we're looking at evidence-based practices, written policies and procedures, a risk assessment process, and thorough and complete documentation, especially if you deviate from your own written policies and procedures. Next slide, please. As we try to wrap this up in a way that's meaningful to the participants, we did look at the cost relationship, both in dollars and cents and the human toll of co-occurring conditions that include mental health and or substance use, and how that cost is significantly higher for those individuals than non-co-occurring conditions. We also looked at the relationship between the co-occurring conditions and clinical quality outcomes. And again, we know that your patients with chronic pain and substance use are likely also trying to manage other chronic diseases that need to be a factor in your plan of care. As Dr. Mason indicated, there is a dynamic interaction between the physical health and mental health that can contribute to self-medication use. We know that chronic pain can become a feeder into chronic depression, but likewise, those people that are experiencing a mental illness of chronic depression or anxiety or other mental diseases can also look for means to mitigate the symptoms of that depression and anxiety through self-medication. So again, we have to really drill down into the causes of addiction and self-medication abuse. We know that opioid addiction in treating chronic pain is a risk factor, and we need to assess that risk in order to protect the practitioners and the practice. And lastly, we looked at the real need to hang your hat as a practitioner and a practice on a solid, evidence-based best practice guideline model so that you can demonstrate to the law enforcement agencies and others that will be looking at your practice, especially if you're holding yourself out as a pain management and substance use clinic, that you're using and making a good faith effort to comply with the regulations and the law, because you have a pre-prescribing plan, you have the documentation and the risk assessment tools, you do ongoing monitoring. But I would also suggest to you that you should give serious consideration to embedding a substance abuse counselor or a behavioral health counselor in your practice. Dr. Mason and I are involved in integrating behavioral health in simple practices for MAG, and I really, from my long-term experience in doing that in Ohio and now in Michigan, I really suggest that that be given serious consideration, because the interaction between mental health and physical health is so profound, especially when you're talking about chronic pain and substance use, that you need to take a serious look at that. And lastly, I would suggest that you need to have an independent review of your chronic pain management program and substance use program. That can be from a third-party outside consultant. It should be done at least annually. Someone that's looking at your policies and procedures and basically auditing you just like law enforcement and other regulators will. If you're showing a good faith effort through the use of evidence-based practice models and adhering to your policies and procedures, you'll go a long way in avoiding problems. Because I can tell you from experience in working in this environment, those of you that are or want to do chronic pain management and substance use programs are standing at the top of a very slippery slope. There are serious ramifications, and more so as the epidemic spirals out of control in some areas on the part of law enforcement and regulatory bodies to make sure that programs that you want to operate are really best practice programs. Next slide, please.
Okay,
Bill,
Richard.
I'll turn it back to you.
Yeah, Richard, Dr. Mason, thanks so much. Before we wrap up, we did have a couple of questions that came in. The first is on chronic pain management. We are considering opening a chronic pain management program in our office. What are a few of the first steps that we should consider?
Well, I would suggest that you really take a hard look, excuse me, as to why you want to do this program. Is it because you think you can do it better than anyone else? Is it because you think you have a lot of patients that could benefit from a program? And define what a lot is, 5, 50, 150, and why do you think you can do it better than others? Perhaps there's no such program in your immediate area that opens the door for you to do this. But start with identifying your real reasons to do it. Make sure you understand the risk associated in doing it, but don't do it on your own. I strongly suggest seek out expertise to help you set up a pre-prescribing plan, your documentation, your policies and procedures, your process for ongoing review, and identifying your comprehensive treatment process.
Very good. And then one more, maybe for Dr. Mason, around patients that are self-medicating. Let's see, what treatment interventions by the behavioral health and primary care integrated team can be used to treat patients that are self-medicating with the potential for substance abuse?
Well, I think that the coordinated effort is, or should be, a lot of therapy challenging the need for the self-medication as opposed to taking their appropriate prescribed medications. And the way I approach that is through a lot of cognitive behavioral therapy approaches, because a lot of times the patient has the irrational idea that self-medicating gives them better results than medication. And it's a matter of doing a lot of education and showing them that no, it doesn't work that way. The less you take the prescribed medication, the worse you're going to get, and therefore you're going to need more whatever you're using to deal with the chronic pain. I think that the other issue there is some of these folks see a real onus in having to take medication. For whatever reason, it's more rational to them to drink a fifth of whiskey, for example, every day as opposed to taking the pain medication. And so I think that there has to be a lot of education, from both sides, but particularly from the primary care physician, in terms of telling them, look, this is what this medication is going to do. This is what it's not going to do. We need to continue to work together, with your therapist to make sure that we're giving you and getting you the biggest bang for the buck for the medication.
Okay, very good. Before we wrap up, I just want to point everyone to the Medical Advantage Group channel established on YouTube. With this being the fourth of our behavioral health series webinar, we actually created a separate playlist where you can hear Dr. Mason and Richard covering all the topics we've addressed, from an overall overview of integrating behavioral health into primary care. We had another session focused more directly on depression, another on anxiety, And later today, we'll have the recording of today's session on chronic pain and addiction. Richard, Dr. Mason, again, fantastic job. Thanks so much for the great overview. For those of you who've joined us, thanks again for listening in, and we look forward to seeing you again in a future Medical Advantage Group webinar. Thanks so much.
Thanks, Bill.